Right. Thank you for Dr. Jayaraman. Thank you for coming. I do December's journal clubs and two articles we talked about this in the past. One is the CODA trial, or the comparison of antibiotic versus appendectomy trial, and the other one's the Stop It trial, which is a guidelines basically that demonstrated when we can stop antibiotics after an abdominal infection. Historically, people have always said 7 to 10 days or extended up to 14 days, but this shows that 3 to 5 days with good source control is just as good. I'll start with the CODA trial. So, it's really interesting to read about this CODA trial. It's a lot of big words: pragmatic, non-blinded, non-inferiority randomized trial. About 1,552 people, and they literally split it down the middle. Half got antibiotics and half got surgery. There's a little bit of a overall measure of health status in order to qualify these patients to be participants of the antibiotic group. So basically, the trial demonstrated the antibiotics is not inferior to surgery. However, there was more complications with the antibiotic group, such as, perforation, surgical site infections, C. diff, which is another big one. And sepsis, peritonitis, the people that were not involved in this trial were people who had complications such as sepsis, peritonitis, or a recurrence, also phlegmon or an abscess. Those are considered complicated, so those were not included in the just antibiotic. The treatment included IV antibiotics for 24 hours initially, then followed by PO antibiotics for 10 days. I know if you read up to date, it calls for Rocephin, 1 time 2 grams IV, and then followed by Augmentin BID for 10 days. And then the discharge criteria for patients to be treated conservatively was they can tolerate half of their normal PO intake, their pain is well controlled, and they're clinically improving, meaning they don't have a fever for 24 hours or white counts coming down. But that's one thing that I noticed. I read on the Stop It trial, and we're always focused on the clinical picture. Patients still in pain, still white counts still elevated, they still have a fever. But they were saying that that's not so much the presence of viable microorganisms, but rather just a continuation of the SIRS response.
So before we go on to this, so what was the difference? I always like to see nice randomized trial in the major journals. What was the difference? How did you? Is this how you get the answer to that question? A study that was interesting because I think for years now, hear about use of antibiotics for appendicitis.
Right. In Europe, they've been using it a long time.
So what was it?
I know because they were doing the study already, but it was the pandemic that really pushed it because they were trying to avoid doing surgery on these patients.
Right. So now we have a reason to try this. They shortened it. We were going to do a year-long study.
Correct, but they had to shorten it because of the pandemic.
Yeah.
Right.
So yeah, that's other important study design. And version that I think sent there's a back, there's other papers. Sorry about that, but you look at the all these studies and basically a flow chart shows hard to see who is excluded in this study and see sort of use with your population. And that's the final thing I'd say is see if this can be applied to your population. Affect how you do your. Since you have it over there, man, you want to highlight something?
Anybody who had abscess, severe phlegmon, free air, ascites, peritonitis, sepsis, cancer, pregnant, uncompensated liver failure, basically like really, really sick. Anybody who's just basic appendicitis problem.
So what's that?
So it's basically non-complicated, like straight non-complicated.
Simple early events.
Right, first occurrence,
With and without.
fecal it, yeah. It's interesting that the group with the fecal tend to have more complications.
Okay, so I knew you were asking like percentage, made it through without research.
I believe it was 25% because within 90 days, I forget the percentage that required appendectomy post antibiotic trial. Forget the percentage, I didn't write it down.
49%. Oh, no. 90. Without an chemical was 25. It depends.
Yeah, it's much higher. That's why I noticed that it was. Yeah. You do an antibiotic trial, if you have an appendiculate, 21% chance.
I mean, I think overall, study, things, use it. In my own personal opinion, we ran a lot of guys all the shots. But I feel that's straightforward. Appendicitis, it's over acute pulmonary, has very low morbidity. So do it, you can hold the same the next day, and it's fine. I think it has there's a role using the caliber for select situations. I think that around here while it wasn't studied in the article, maybe we don't need to push the envelope as much as high order. Elderly, low life expectancy. Or, I think there's a role potentially in, times of surge, when we have decreased water availability and things of that nature, we have no bed, transfers, maybe some buffer really happy, but ultimately, I'm a big believer in people out of the hospital, if possible, but for someone that carries very little over, just take it out and come with it. I would agree. For a wide and people.
Especially with the recurrence, the recurrence rate being so high.
Right, so then you're bringing people for 2 admissions or
Double the cost.
What is your
But the people without appendiculate was 25%. Oh, pardon me, without 25 and with 41.
I don't remember I read this one. Did you talk about people that you do a delayed appendectomy? If they have all these claims to engage from one, putting it all,
Let's talk about recurrence.
because that would be, I think, really important use of it.
Yeah, the way I was thinking about this is potential use How do you operationalize?
Setting.
How do you operationalize? We could do, to give something that goes.
Drug coverage 24 hours, right?
So eventually, it's some hope.
It was just Rosetta, IV Rosetten, no, they didn't ask for Flagyl, which I was surprised, and then followed by 10 days of PO augmented.
Yeah, so do that. I see the other day. I was just came in, and it doesn't offer Friday night. So came in, and a lot of days getting out about next day is like the jumping jacks. And I saw it that was happening. But my point is that was the so we have the system sees it. Use that part of 24%. Big number. Definitely someone that we can explode questions asked. We can give them the option of lay down patients or
Straightforward, young, no no major comorbidities, no appendectomy.
It's like a tough spot because most people, the straightforward, are usually the easiest ones without, I think again, I think in our situation, this uncomplicated stuff that we get in our transfer, I think there's a role, I'm less burdened on this page.
and maybe one option. The other option is within our system we have inside of the tool. They're really or the next day. That's the antibiotics schedule.
Yeah, well, my only thing would be like the guy was all example. It kind of wasn't feeling so hot first day, and for the second day. Like, how quickly are they gonna have a response to antibiotics for your treatment? And clean launching the first hour less. How long is that gonna take?
That's
It's gonna take one guy to have a problem that I want to play along.
I think those are. That's why this will be more of a discussion than just. But if people are interested, I might make a little protocol.
Yeah.
Work.
And we've used this protocol for the trial. Earl and I did it one time. It was a young kid who was like maybe 19 or 20. He was from out of town and saying that he didn't want surgery. He's like, can I just get some pain meds and something? We told him, well, there's another option. So you're very straightforward. Obviously, we didn't follow up on that because he left, but we gave him IV Rosetten and the ED, gave him a prescription for 10 days of augment and then sent him home. But that was because the kid didn't want to have surgery here. He was like, I just want to go. I know I'm in pain. I know I need surgery.
So that's another indication. So people who are out of town, who want to stay, who are transfer in and take up a hospital bed. They don't have an OR in sight.
I think
Otherwise, ideally, appendicitis should come, have a room to do the surgery, and then get discharged from the bed. They should, those simple ones, they should not.
I mean, if we had all the resources we needed, you come into the ER, have your operation back home in a half a day or less.
Absolutely.
But we don't have that always here. I think it comes down to everybody has to take this algorithm, you put it in your back pocket or in your tool belt, and as opposed to, for young people that we've talked about not having a cookbook per se, I don't think you're going to have you're not going to have a hard black and white set of guidelines of when you use this. I think you have to think about each patient situation, who this makes sense to use it with.
Okay. I'll say a couple of things about the other one.
Yeah. The other study is the trial of short course antimicrobial therapy for intrabdominal infections.
Before you start, I want to just call your attention to a couple of things. So again, England Journal, pretty well reviewed, randomized trial. If you look at the authors, it's really interesting to me because most of them are surgeons, and this is a surgical study. So it's very from a validity standpoint, it tunes into what we do a lot, and I think specifically it's about patients who have a surgical intervention and how long to treat them with antibiotics because of that initial sepsis. All right, go ahead.
So this study involved about 518 patients who had complicated abdominal infections. After they had adequate source control, the antibiotics were given a minimum of 2 days after they had their fever resolved. And there was a maximum of up to 10 days, which, is the question whether 10 days of antibiotics is the same as 4 or 5. Some of the complications that they saw were surgical site infections, recurrence of abdominal infections. 56 out of 257 patients were in the experimental group, and the other were 58 out of 261 in the control group.
So those complications listed were for both groups.
Right.
Those were the outcomes.
And the conclusion was basically that 4 days of antibiotics with appropriate or good source control is no different than a long course of antibiotics, historically 8 to 10 days.
So let me ask this, Elena. So you have a person that perforated diverticulitis, and they went to the OR on hospital day 0. They had a Parkinson's procedure, they had abscess that was draining, there's some stool there as well. So pretty nasty abdomen. Everything is washed out carefully, and drain was placed. Drain serous sanguinous. When do you decide to stop the antibiotics?
Well, according to this,
No. Let's current state. Let's look at current state. What do we do?
current state, well, if we have source control.
Okay.
Yeah.
So if they had abscess or fecal contamination, we almost say that that's almost like fecal peritonitis, T3, 4 those need antibiotics for longer. The question is, when do you stop? What are things that you would take? Make sure you could stop antibiotics.
What I was.
Yeah. Okay. Yeah. So when would you choose to stop?
When your white count is, very febrile, make sure that the drain is serous sanguinous, doesn't clog.
That's
So,
one thing that they mentioned,
That's an interesting thing.
That's one thing that they mentioned. That's historically how we always have looked at, this is when we should stop the white counts down, the fever, the having this pain. But they talk about one thing that I never consider is if the white count remains persistent elevated the day after, you've had 3 or 4 days, more than likely it's not a true ongoing infection. It's just a persistent, exactly. Inflammatory response.
They use one more criteria, which I thought was interesting. They used recovery from illness.
Yeah, they talked about that too.
Use that.
No, I don't think I've never used.
That's an interesting one.
But the thing I didn't understand about that is because not every patient gets disease, So I guess if you do get one, when it's resolved is when we can say, your infection is resolved too.
I feel like it's hard, because some of our
Very
patients
hard.
literally like are having gas, not in about 4 days.
Right, and they're still-
Really have a normal weight count, afebrile, participating in the, feel like you shouldn't be keeping antibiotics, just that.
I think, really short of Jason, me and Pete, maybe Rebecca, I mean, I would have seen tears fall from your eyes if you saw our antibiotic stewardship 5 years ago. I mean, Zosyn was known by some on the surgical service as the magical healing drug. So we use that for the entire duration of somebody's stay, 10 days, 2 weeks, like the ICU bangers were forever. And I found this article years ago, and I really started like when we started to turn the corner, because basically ID started to figure it out. And then some of the surgeons just stopped consulting ID because they didn't want to listen to what they had to say. We just do it forever. And then we got better stewardship in terms of not using Zosyn. The neuropenims were things I saw somewhat frequently. We did crazy stuff back then. And then, anecdotally, I mean, we had patients that were sick, perp, divertics in the ICU that had real disease that we do a 5-day course and they would do just as fine. And I think, obviously the study supports it, but anecdotally from our practice here, it was very hard to adapt because we treated people so aggressively and so broadly for so long. But once we finally got better, it's better. And I think for, again, Team Newbie, for you guys to have good stewardship, and like I try to be very good and as a habit when I write progress notes, when you guys write, your antibiotics for Cephin and Flagyl, like put in parentheses day number blank out of blank, so the next person that comes in can follow that and realize where you're at. Because that's what happens is if you don't have a stop date or you put it in your note, people become complacent and they forget that they're there and they just keep going on forever.
All right, change.
Yeah.
I don't think I do that routinely.
But this trial shows it's not inferior.
No.
I think the impetus for this trial was to see if growing superbugs or stuff you get from lungs. The other study that similar to this, the 10 years before this one was the one for ventilator associated pneumonia. They could do for 7 days or 14 days. Similar results and see a difference.
The only thing I see with this thing is the patients who are immunosuppressed, because it's only some of them were included. That's still a little tricky.
Yeah, this is not for everyone. So the inclusion criteria is
Yeah, I mean, I think looking at patient situation and making this is something you gotta do this longer. It's just what your gut tells you to do and kind of experience. Like, I think this OB lady over here that I sent home today is kind of an interesting case in the sense that we're sending her home with a white count of 16 or 17,000. That will probably make some people a little sketched out, but her and her husband, they're somewhat high maintenance. They are buying charters and they follow the numbers. And I told her yesterday, the lab value is just one piece of information you use to look at your picture. Like, it's not the tell all. It's in combination with the febrile, the drains, the exam, all that stuff you talked about, Elena. But I told her ultimately, like, we treat patients, we don't treat numbers, right? You don't just bolus people based off of blood pressure you see in a chart. You don't just do something based off a lab value you see, right? It's all in context and how they're doing. She looks amazing. She's totally pain-free. She looks good. Her drains were clear. She obviously had a significant intra-abdominal process that was probably lingering for several days, as it was probably what she came in with before all this happened for 4 days. And granted, she has this intraloop abscess, which makes things a little bit more complicated. But ultimately, yes, she has a white count. The overall trend over the long hauls, it's going down, albeit slowly. But some of it's probably reactive. Some of it's probably from the abscess. And if she had the abscess, I think clearly warrants her going home on further antibiotics. But you'll see some of these intra-abdominal bombs. these guys can probably vouch for it, we've seen over the years. Sometimes they take like weeks for their white counts to normalize. But we'll have like significant, fecal peritonitis, divertic, perf stericals, or stuff like that. And it just, you don't necessarily need all the antibiotics, but it's just going to take a long time for that white count to go down. And some people feel very uncomfortable stopping it, but sometimes it's okay.
Yeah, I feel like a general rule we've been following is I have it. It's just 5 days.
Yeah, 3 to 5 days.
All that, but that's like our rule.
Yeah, and I think generally that's pretty well supported by, there's going to be certain circumstances, but as a general rule for most straightforward patients, it's generally more than enough. And then, like gallbladders and the appies are unique in the fact that I think I read some study a long time ago that a large percentages of gallbladders, if you actually culture them, will grow out nothing. So there's really no infection to begin with. The appendectomies are not perforated, they're well controlled when you take that out, they don't need anything. But it's funny to look back 5 years ago and see the horrible things that we did. And we wonder why everybody came back and see that, but it was.
See that, Joey?
Because you'd show these articles to people that were more prevalent back then, and nobody would give a shit if you. I mean, honestly, they didn't give a shit about you trying to prevent the superbug of tomorrow when they're 50-something or 60 years old. They cared about their patients today, but at the end of the day, it made no difference. They did just as well.
Right. I think, this is meant for, in the trauma world, we have fracture the abdomen and stool spillage and actual fecal peritonitis that's been dwelling there for 2 to 4 hours before you get to it. What to do with that person? Like a colitis patient is perfect. You don't see them for 8 hours and show up and it's like belly full of stool and pus everywhere. So that's the sort of case that this is highlighting, that they don't need the 14 days of antibiotics. You're in the OR, you would think that you want to treat them. How long do we treat Longoria?
Well, she's about 17 days post-op, or sorry, about a week post-op, and they're sending her home in another 7 days. But they also changed her regimen a little bit. She still has this abscess.
Yeah, hers is very different.
She's a little bit.
She still has a.
She had very delayed source control. She's a little bit more complicated, but I think she's an interesting case, as in, like, sometimes we get into this habit of, everything's got to be stone cold normal before they can hit the door. But she was a little concerned yesterday, and I said to her, I'm like, look at you. You look great. You're moving around. You're eating. You're pooping. You feel great, and all you're hung up on is this number. I'm like, at the end of the day, you're going to take PO antibiotics, or you're going to take antibiotics, and you can either sit in your own bed and do this, or you can sit in our bed, put the pill for it, and then you're going to follow up in the office, and they're going to check your blood work, just like I'm going to do here. And people do better when they're not in the hospital. So eventually she got on board with it. She realized that she was just hung up on a number when really she was looking and feeling fine. And now she's home. But I think it's also sometimes it hinges on the right patient that's going to follow up, et cetera, et cetera.
That's what, goes back to the POTA trial is these patients, how many in this particular area of Connecticut, how many are going to be compliant with 10 days of twice a day antibiotics?
Much for me to do.
A patient, I mean, that trial is only, that treatment's only good if the patient actually does it.
Yeah, and I'm also not sure if 10 days is the right answer. You could marry the 2 trials and you could probably treat 7 times for 4 days. As long as you're seeing them within the time frame.
Right. Definitely have follow-up, Just here's some antibiotics. Good luck. Cool. Does have any questions, comments? Sorry.
It was a good discussion.
The next trial.
I have to reschedule Casillas for January. So maybe, I don't know, February, March. So I haven't sent my invitations for the year yet. I usually do it in January, early January.
There's gotta be some article floating out the world that's got Jayaraman as one of the authors, huh?
This is good on the chess ball.
Oh, yeah?
Oh, the chess call.